Good morning, everybody. So I think, surgeons are well-versed in kind of the science behind a lot of the common spine pathologies. And I think the goal is to make the patient as knowledgeable about, their disease process, especially as they get older. So I figured I would talk to you a little bit about the concept of priming and how it relates to kind of our overall delivery of care for patients. So these are my disclosures, not really relevant. We'll talk about the concept of priming, challenges with spine, patient decision-making, and then priming patients for success. And then I'll give you a brief case example of how this applied in my own practice. So what is priming? It's making something ready for use or action. So if I ask this crowd like bread, juice, milk, and I said, okay, what is the letter that's missing there? Like how many of you would say it's a U for soup, right? Good. So, but if I gave you this one and I said towel, shower, shampoo, and I said, what's the letter that's missing? You'd say an A, right? For soap. And so what that is it's preparing someone for a situation or task, typically by supplying them with relevant information. And this, I think, applies to our overall concept of spine surgery when we think about counseling patients. So we know that spine surgery is common, it's complex. There's a multiple range of different pathologies that kind of fall under there. And all these patients come with a wide array of different symptoms that could be mild all the way to severe disability. And we know that the incidence is increasing over time, and these patients are at risk for poor prognosis and low health-related quality of life. But the other thing that we oftentimes neglect is that these patients often come in with very, very high patient expectations, and especially as they come across their overall burden of disease in the natural history, those expectations can sometimes get, much higher. So like I said before, they have functional impairments, disability, concerns for limited life expectancy. And as the provider, when they see us, they say, hey, our goal for them is to maximize their quality of life and their quantity of life by limiting their complications, limiting their potential for mortality, getting them out of the hospital, getting them back to walking. And so I use this cartoon as a description of how a lot of surgeons see themselves of like, we need to avoid complications because it'll be kicking that patient kind of off of that cliff. But one of the things that we de-emphasize is that cliff is actually composed of their expectations and that patient's homeostatic reserve. And I think it's important to understand kind of where that patient is in their disease process and the contributions that may make in terms of their tolerance to the procedure, as well as the potential outcome and how they view it. And so I like to quote, the gangster poet, Pulitzer Prize Award winning poet Kendrick Lamar, and that I realize that life is perspective and my perspective may be different for yours. And I think that's important because when we're looking at it from the surgeon perspective, we look at these patients as, hey, this is the disease, this is how we're going to put this together. But we also have to think about it of how they see things. And so we have to think about how do we prime these patients for these shared decision-making. We know that spine disease can be complex. We know that there's a mutual understanding of the goals, benefits, and risks. But I think you have to recognize the influence that a patient's cognitive or physical frailty at that specific time point in their disease process relative to that patient's expectations and their homeostatic reserve and how that actually affects their decision-making. And so this is a patient-centered approach to decision-making, and it goes over everything in terms of their attitudes, perceptions, cultural norms, communication barriers, the providers' knowledge and expertise in the field, and it goes in a very complicated thing. But if you ask patients kind of, how do they actually formulate it, they'll actually tell you about the cognitive and the physical factors that alter their decision-making. From the cognitive standpoint, one of the concepts that we've studied is distress. And so we can take that simplified model of that patient-centered thing and then base it on what patients actually do. And what patients will tell you is that their decision-making is really based off of those categories, which is praying someone else makes the decision. We know that the majority of times patients actually prefer for physicians to make the decision for them, panic, thinking rationally, or flipping a coin. And we know that that is actually influenced from studies based on their overall distress at that specific point in time. And that influences kind of what their outcome and what they expect from it. That's from the cognitive perspective. From the physical perspective, we have to also think about where that patient is along the natural history of their disease process. So whether they're, walking or whether they're disabled. And really, when you think about frailty, you think about that patient phenotype of multi-system diminished physical reserve or capacity that predisposes them to a worse outcomes. So whether they are robust or whether they are frail or whether they are disabled. And so when you think about that homeostatic reserve, you're really talking about, can those patients actually accommodate stressors that we put in them? And so that is for the patient that's walking, how do you get them to keep walking, and all the way to those people who are frail, who are basically going to be disabled no matter what you want to do. And so how do we assess that? Well, usually we use the eye test as physicians. And I think that one of the things that we need to keep in mind is that, meeting the patient's expectations and priming patients for success is dependent on how we are primed to evaluate a patient from that physical and that cognitive perspective. And so what can you do to kind of do those? Typically we think about the pre-optimization criteria, such as prehabilitation, bone health, nutrition consultation, addressing their comorbidities and whatnot. But then we also have to think about how we get them ready cognitively, right? And so, in my clinic, I use verbal and written risk sheets, palliative care consultation for goals of care, multi-deep discussions, psychological consultations, stress management. And we've even started a spine navigator program with students where we actually get them paired up. And so they serve as an additional conduit for patients to actually have an outlet to get some of their questions answered. I think the most important thing, and this is kind of what I'll bring up, is that it's all about setting expectations early. Similar to, my hero, Kermit the Frog, I think that one of the things that you have to remember is that, it's all about how you set that expectation for the patient early, and you basically have the conversations and talk about the things that are harder for people to actually discuss, especially when these patients are going through the pain, the disability, and have all of those other, hopes and dreams, if you want to call it, in terms of what this surgery is going to do for them. And so I'll leave you kind of at the end with a patient of mine and kind of to illustrate the point of priming. And then, so this is a 45-year-old male, thoracic epidural abscess, presents a 3-month history of back pain, ended up having a malignant round cell neoplasm. Basically, the tumor board recommendation was for an en bloc resection. Ended up running him through every single category to try to mitigate all of the different risks associated with everything. And then at the end of the day, we ended up doing this T1 to 6 en bloc tumor resection, chest wall, ended up getting negative margins. This is what the tumor looked like at the end. And then came all the complications. We ended up having hardware failures, washouts, plastics flap reconstruction, you name it, over things. And then, when I counseled him, I told him about, hey, you're going to have at least one complication, wound dehiscence, instrumentation failure. And even though my goal is going to be to dodge these like the Matrix, I can tell you they're coming. And I think that one of the things what that told me is that he was primed to expect that complication, and he had the best attitude toward it. He was like, hey, if that's what it is, that's what it is. But it was all because he felt that he understood the team, and we had a team that was behind him, that was supportive of the whole process. And all he cared about was who cared about him and who was willing to talk with him about those. And so this is him at the end. And so I'll just summarize this by saying that, it's all about balance. I think that, one of the things that we have to do as physicians is think about what are our surgical goals, what is the frailty of that patient, what's the invasiveness of the procedure, and how can we use those to get optimal outcomes that meet or exceed your expectation. And really what it's about is creating the right environment, doing the right surgery for the right patient for the right reasons to get the best outcome. So with that, hopefully you've seen kind of how you primed, and I hope you guys go out and you prime your next patients for optimal success. Thank you.